Thank you very much for your kind introduction, Dr. Edwards. I'm going to apologize in advance for any background noise because they are re-roofing our condo. And so you may hear lots of pounding, but they appear to be in a lunch break, so that's good. and I wanted to send thanks to my resident economist, Alan Goodman, who helped me with some of the economics in this talk. Also, turns out there's very little information in the academic literature on these topics. And what I'd like to do is to ask you to wait with all your questions until I finish my talk. I think that will be more effective. So, can everybody see my slides? Yes,
no?
No?
You have to reshare.
Okay, sorry. Okay, can you see now?
Yes.
Okay, great. So I'm going to talk about the impact of the pandemic on our healthcare system, and there's basically good news and bad news. As we begin the third year of the COVID-19 pandemic, the U.S. has recorded 947,000 deaths from COVID-19, and close to 79 million Americans have contracted the virus. Today, I'm going to focus on the pandemic's impact on three elements of our healthcare system. There's certainly many more. But I'm going to talk about the loss of health insurance, problems accessing ambulatory care, shortages of personnel, hospital beds, and equipment, and I'll describe the problem and then also talk about efforts to resolve the problems. So, how many people were uninsured in 2019 before the pandemic started? 92% of our population had some sort of health insurance during 2019. They may not have been covered the whole year, but they had health insurance. 56.4% of health insurance was employer-based. So if you look at this graph, you'll see the 56.4%. A total of 68.0% had any private plan. 34.1% have public plans, most usually Medicare for the elderly and Medicaid for poor and disabled persons. The totals here are greater than 100% because people can have more than one type of health insurance. So many people who are 65 and over have Medicare plus what we call Medigap to pay their other expenses that Medicare doesn't cover. And some people have both Medicare and Medicaid. So the prime question is, how many people became uninsured because they lost their job in the pandemic? And Frost and Woodbury reported there were 2.2 million people unemployed in March 2020, just as the pandemic was starting. Now, this had a very particular definition, so they had to be filing in that month for uninsurance and deemed eligible for the benefits and have had at least 1 week of unemployment. However, by May of 2020, 18.5 million people were unemployed. And they estimated that there were 14.6 persons who lost employer-sponsored insurance. 7.7 million were the workers themselves, and the remainder were the individuals who had children and spouses who were covered by that. So let's take a look at, what this means in terms of how many Americans are uninsured. The CDC, along with the National Center for Health Statistics, developed the Household Pulse Survey. They collected data on how coronavirus was affecting the number of uninsured. And the survey that was conducted during April 23rd to May 5th, 2020, discovered that 12.6% of all Americans were uninsured on the day the survey was conducted. Compare that with the previous table, which showed that before the pandemic, only 8% were uninsured. So 41.6 million people were uninsured. And as COVID infections rose, this number of uninsured rose too. But there is good news. The number of uninsured population has dropped. And basically, by January 6th through February 7th, 2022, only 10.3% of Americans were uninsured, according to the Pulse survey. Michigan had only 6.3% uninsured. So, how did 7.6 million people get insurance? Well, it turns out that some individuals, some employers, kept paying part of the premiums for the insurance for workers who lost their job. And the federal government provided funds to encourage enrollment in the Affordable Care Act. And they also lowered insurance programs in what we call the ACA. So, hang on. Okay, sorry. The updated data from Fronstein and Woodbury showed that about half of employers continue to pay health insurance for their former workers. And basically, employers in the accommodation and food service sectors were less likely to help their former workers compared to employers in the manufacturing sector. And Fronstein and Woodbury note that it's not clear, however, how long these payments will continue and if the pandemic persists. The federal government took some important action as well. Recall that the Patient Protection and Affordable Care Act, aka ACA or Obamacare, started in 2014 to provide health insurance for Americans. The ACA developed what we call healthcare exchanges, where persons could purchase the affordable health insurance. In addition, states had the option to expand their Medicaid program using government subsidies. All but 12 states have expanded Medicaid. The most conservative states have not done it. Open enrollment allows you to enroll for one of the programs under the ACA, but the money to market the Affordable Care Act was dramatically cut by Trump, and the enrollment period was shortened. And as a result, fewer people enrolled for insurance under his regimen. 80 million dollars was set aside from the marketing campaign, which lengthened the enrollment period, hired more navigators who actually help individuals find an insurance program that they can afford, and also help them enroll in them. The American Rescue Plan of 2021 eliminated the income cap to purchase insurance from the healthcare exchanges, and it increased the subsidies for persons buying insurance, as well as lowered their premiums. As a result of Biden's efforts, the ACA enrollments in the beginning of this year were the highest ever. It jumped to 15.5 million people enrolled. And what happened is that the health exchanges and Medicaid took the place of the employer-sponsored insurance, which people lost when they lost their job. However, the subsidies in the American Rescue Plan terminate in December 22 unless Congress takes action to continue them. So that's the first problem that I wanted to discuss, the issue of insurance. The second problem is accessing ambulatory care. Now, the Pulse survey asked 2 questions to get answers to this. One was, at any time in the last 4 weeks, did you delay getting medical care because of the coronavirus pandemic? And at any time in the last 4 weeks, did you need medical care for something other than coronavirus, but did not get it because of the coronavirus pandemic? If you look at this graph, you'll see the very first estimates suggested it was about 40% of people who delayed care. But by the time we got further in the pandemic, this was a less common happenstance. The graph shows during the period April 23rd to May 5th in 2020, 38.9% delayed care. The peak in the delay, which was 41.5% of respondents, occurred between June 25th and June 30th, 2020. However, by June 19th to the 21st in 2021, people who delayed care represented only 16% of the respondents. A variety of reasons have been given for delay of care. It can be the cost, canceled appointment by the provider, cutback in transportation, fear of going to the emergency room, or desire not to be a burden to the healthcare system. One solution to this was telemedicine, otherwise known as telehealth. And after the passage of the CARES Act in March 2020, the Centers for Medicaid and Medicare changed its rules so that healthcare office settings could provide care and be paid for providing care to patients through telemedicine. Private insurers quickly followed suit and paid for this kind of care. Government data from the MMWR reported that comparing the last week of March 2019 with the same week in March 2020, there was a 154% increase in telemedicine. And most of these visits really handled the problems for persons, and their healthcare could be treated and managed at home rather than telling them going to the doctor's office or urgent care or to the emergency room. So that was a good thing that certainly happened. When we look at what happened with telemedicine, here is the telemedicine use that went on. And what are the benefits? Well, it's expanding access to care. It certainly reduces the disease exposure for staff and patients. It provides scarce supplies of it preserves the scarce supplies of personal protective equipment, gowns, masks, gloves, head shields, face shields, and it reduced the patient demand on facilities. But we still need more information about the quality of diagnosis and medication, management and telehealth encounters. Are the patient outcomes the same for telehealth and in-person care? What about diagnosis and medication management? Are some conditions more amenable to telehealth than others? What groups find it difficult? I mean, there's evidence thus far that people who are in ethnic and racial minority groups, elderly, non-English speakers, and persons with limited access to the internet are less likely to be able to use telehealth. Now, here's another solution that was developed to deal with problems in getting access to care. There's a concern about the delay in screening for cancer. There was a story by NPR about the drop in cancer screening. Many people are not getting screened. So the delay results in fewer cases being diagnosed early at stage 1 when it's easier to treat and the outcome is better. Pre-pandemic mammograms found 64% of breast cancer cases were stage 1 before the pandemic. During the pandemic, only 51% of the cases were diagnosed at stage 1. So you're getting patients coming in later, they're harder to treat, their outcomes aren't as good. So in short, we've really found that screening for breast cancer, lung cancer, prostate cancer, and bladder cancer, as well as colonoscopies, have dropped during the pandemic, and that's not good. So we expect to see some rises in death rates as a result. How can we encourage cancer screening? Well, Dr. Connie Lehman at Mass General Hospital in Boston created a unique program to encourage women to get their mammograms. Often you have a mammogram and you have to wait days to get results. If an abnormality is found, it can take weeks to schedule a biopsy. And this discourages women from getting the screening, especially during the pandemic. So Dr. Lehman came up with a solution. She offers mammograms and promises results in a short period of time, just after they have the mammogram before they leave the clinic. If they need a biopsy, she offers it for the same day. This has really encouraged women to get more mammograms, and it's a very clever solution. And she has the manpower to be able to do that. So that's something that we want to continue to think about as an option. The last issue I wanted to talk about was shortages of personnel, hospital beds, and equipment. The pandemic put stress on all parts of our healthcare system. The American Hospital Association states the pandemic continues to affect communities across the country and has pushed our healthcare system to the brink. In the face of mounting financial challenges, it's estimated to be $54 billion in net losses in 2021 alone for hospitals, because they have cared for over 3.2 million COVID-19 patients since August of last year. So one of the key issues in the shortage is the nursing shortage, and I'm sure you've seen lots of headlines about this. The demand for hospital care increased for hospital nurses increased 245%, 50,000 nurses between 2019 and 2020. Job vacancy rates have increased to 30%. The job stress of caring for COVID-19 patients has caused burnout for nurses and impacted their mental health. According to the New York Times, 66% of critical care nurses said they were thinking of retiring. It's also important to understand that only 153,000 new nursing graduates are licensed each year. And the American Nurses Association estimates we'll need 1.2 million more nurses in 2022. They did a survey of almost 10,000 nurses and found that 25% of them were planning to leave their job in 6 months. And an additional 60% were thinking of leaving because they were so stressed. So what strategies exist to mitigate healthcare personnel, which are abbreviated as ACP, staffing shortages. Well, one is hiring additional HCPs, recruiting some who've retired, using students or volunteers. Another option is assigning administrative staff to patient care. The CDC suggests addressing healthcare personnel's problems with housing. You know, how can they protect their family? They really need to move out of their house if they're being exposed to COVID every day. Transportation to the hospital, childcare problems. They've also promoted emergency waivers of licensing requirements. So if you were licensed only to practice in New York, you could become a nurse in Michigan without waiting for the license board to approve you. They also suggest allowing someone with high-risk exposure to COVID and not up to date on vaccines to return to work if their COVID tests were all negative. So what's the story with travel nurses? You may have seen a lot of it in the news. There was a big article in the New York Times a couple of weeks ago. They earn $8,000 to $12,000 a week or more. Compare that to the median annual pay for a critical care nurse in the US, which is $72,541. There were 30,000 job openings for travel nurses in December 2020. It's very costly for hospitals, but they really had no choice if they wanted to take patients. Some of them have decided to give signing bonuses to nurses who want to work with them of $25,000 if they agree to stay for 3 years. The federal government has helped in the Biden administration with the CARES Act and the American Rescue Plan. It's a federal money so hospitals could hire travel nurses. And the armed forces have assigned nurses to work in hospitals. To address the personnel shortage, Defense Secretary sent 1,000 military doctors, nurses, paramedics, and other medical personnel to hospitals during the first 2 months of this year. And 6 emergency response teams were sent to various states, including Michigan. Another shortage issue is hospital beds. In the 14th of January, the headline screamed, 19 states have less than 15% remaining capacity in their intensive care units. 4 of them have less than 10%. New research shows that when hospitals become overburdened, the consequences are dire. Patients are more likely to die. One study found that nearly 1 in 4 COVID deaths was potentially attributable to hospitals strained by the surgeon caseload. And there's been another study that showed that COVID-19 surges were associated with higher mortality rates among other kinds of patients too. That was from NPR. So what have hospitals done? Well, they've canceled non-essential procedures. They've kept patients in emergency rooms while they're looking for beds. They erected field hospitals and parking structures. The Federal Emergency Management Agency is working on the issue and will pay for increasing hospital capacity. And FEMA is sending hundreds of ambulances and emergency medical teams so when a hospital fills up, patients can be transferred safely to other hospitals who have empty beds. Now, a big problem too is hospital and personal shortages of masks, goggles, face shields, gloves, refrigerators, ventilators. These are continuing. To understand some basic explanations for the shortages, think about manufacturing the equipment. In other words, you have to get the raw materials, and they've been scarce. Procuring the equipment. Can you purchase it? Can you get it shipped? Can they get it off the boat and deliver it to you? Storing the equipment. Where can you store it? It's very expensive to have storage facility. And is it in the right place at the right time? So if you have limited equipment, you want to identify some centers of the United States where you could easily get the equipment from those particular centers to the state that really needs them. And then you have to worry about maintaining equipment, and some of this deteriorates over time, and that's not good. And these are the issues that can explain some of the shortages that we're experiencing. There's also a really good graphic by Cohn and Vandermuller Rogers that looks at 4 different components that contribute to the basic shortage problem. One is hospitals. They want profit. And if they buy equipment that they don't need right away, they may start losing money. So they're often looking at short-term purchases. On the other hand, personal protective equipment benefits their healthcare workers, and they have to provide it. We also see what's called the demand shock, where healthcare systems need it, consumers need it, and people are starting to hoard these kinds of things. There's government failure. The Trump administration, they were unwilling to use emergency power. They had not kept the federal stockpile replenished. Some items in the stockpile expired, so they couldn't be used. We were in a trade war with China, and we had minimized in the beginning the COVID-19 severity. And then below, you can't see this particular block, but it's really relates to the supply chain. So we have an overdependence on imported PPE. We kept exporting PPE to other countries who needed it, but then we had competition between countries and states because it wasn't being very well managed. So those contributed to the problems as well. So what are some of the solutions? Well, some manufacturers were able to retool what they made in their plants and instead made masks, gloves, and shields, as well as other equipments. Many people started sewing masks and making face shields, and some of these were sold on the internet, and that was very helpful. And healthcare workers created their own gowns from large plastic bags, which is probably not the best, but it's all they had available. Biden's plan to address the equipment shortages is they're going to position the following equipment from the national stockpile, so they have it in place where they need it in these big storage facilities in various parts of the US. So the masks, the gloves, the gowns, and the ventilators. And these will be shipped when they are needed to the states. So, conclusions. The COVID pandemic revealed the problems with the healthcare system, and I focused on 3 of the outcomes: the loss of health insurance, the problems in accessing ambulatory care, the shortages of personnel, hospital beds, and equipment. But there are many more problems, and we just don't have time to discuss them right now. The pandemic has sparked changes in the healthcare system to meet some of these challenges. And while they've resulted in some improvements in our healthcare system, we still have the overall serious problems of access, cost, and quality of care. We still have many uninsured Americans. These individuals are members of racial and ethnic minority groups, poor, and have less than a high school degree. Our country spends more on healthcare than any other country in the world, but we get less bang for our buck. And the quality of healthcare in the United States lags behind other high income countries. So my bottom line is that the challenge of the COVID-19 pandemic has resulted in some positive solutions to the existing problems in the US healthcare system. The lessons we've learned can help us make changes and ensure that high quality healthcare is available to all Americans. Thank you, and I'd be glad to entertain any questions.
Thank you so much. Actually, if you have any questions, use the reaction button to raise your hand. And I see that.
Are you going to handle the unmutes?
Yes.
Okay, great. Hi.
Hi. I liked your presentation. I like for the short time that I saw it because I came in late. But I'm wondering, do you know how much the amount of disability itself, mental disability, has shaped the way how nurses work and how taking advantage of their mindset kind of made them a bit insane because of the pandemic, and will take effect even after the pandemic? Do you know?
Oh, it's clear. There have been various reports of nurses who have left the profession, and they're still suffering. And, we have a shortage of mental health services now, and it's not going to get any better. So that's a very important issue that needs to be addressed so that we can, provide support for all these people who are basically risking their lives to take care of patients.
Yes. Okay. Thank you.
Thanks for the question.
Molly.
Hi, thank you. Hi, it's nice to meet you all, and thank you so much for your presentation. It was very informative. I teach as an adjunct the Introduction to Public Health, and also teach at some other universities. And I'm just curious, from what you've read or seen or heard, do you feel as though all the problems associated with the COVID and the healthcare and access has pushed forward at all the argument on Medicare for all?
I've not heard any attempts to link that to Medicare for all, but there certainly are various proposals being considered to make sure that every person in the US can get healthcare coverage. And the discussions seem to suggest that expanding the Affordable Care Act, like we did during the pandemic, might be the quickest way to get that done, because you wouldn't have to start a whole new structure to get people insured and to have them drop their current insurance in Medicare and Medicaid and private insurance to get into this nationalized program. So that's kind of what I'm hearing, but I really haven't seen anything definitive on that. I think people are very much focused on the here and now and getting through the pandemic, but that's a really good question.
Yeah, it just seems like it's, everybody's health insurance seems to be so highly tied to their employment, and obviously so many people lost their jobs. But yeah, thank you for your comment on that. I appreciate it.
You're welcome.
Hi, Janet.
Hi.
Nice to see you. I had a question about, so you were talking a lot about insurance and sort of how people were losing their insurance during the pandemic. My question is, when people were, especially back in the beginning, when people were coming to the hospital and presenting and were really sick and being admitted, were they being charged for those? So, I mean, are there accounts of people who had to be hospitalized for long term during the pandemic who didn't have health insurance who then got a bill for, some exorbitant amount of money? Has that been something that we've seen?
Unfortunately, yes, but there have been a lot of efforts to get those costs covered by giving hospitals some more money and immediately, putting people on, for example, Medicaid, or getting them enrolled as soon as they can into the Affordable Care Act. I mean, there's some horrific stories of very high costs. And one reason the hospitals are so much in debt is because they're giving that care for free
Yeah. So it was really just kind of case by case, depending on which hospital you happened
That's
to
my
visit, as to
understanding.
whether they ended up charging you $30,000 or nothing. There was no federal policy.
Not under Trump.
Thank you.
You're welcome. Lance? Gable?
Okay, there
Hi.
I am. Hi, Janet. Nice to see you. So I have lots of questions, but I guess the one I wanted to ask first, in terms of of kind of where we are at this point in the pandemic, having, I mean, I think you brilliantly laid out a lot of the challenges and some of the opportunities too. Early on, it seemed like there was this huge amount of solidarity with, across the population, but also with, in particular, healthcare workers, and people were describing them as heroes, and there was kind of, and that plus some of these policy changes to try to support them seemed like we were moving in a very positive direction, even though there was a lot of countervailing policy moving in a bad direction in terms of some of the federal policy that was inhibiting the COVID response at the same time. I feel like at this point we've reached a point where there's that solidarity or support for healthcare workers has really begun to fray in some, and just like support for public health measures against the pandemic have begun to fray, and I'm wondering how that affects the landscape of sustaining some of these successful policies. People are not feeling as supportive and as charitable towards people working in the healthcare system as maybe they did, or is that a misreading? Maybe that goodwill is still there. I guess I wanted to get your sense of kind of where we stand, kind of politically and socially, in if we were to try to extend and push forward some of these measures that have really worked well, and to try to reverse the ones that are moving in a bad direction. How do we marshal that support, and where do we stand right now?
I mean, that's a really interesting question. I think that the support is still there. It's just not as vocal because, people have gotten tired of standing out on their porches and banging cans and pots to support the healthcare workers. And the healthcare workers, are leaving their jobs. So they're not feeling supported, certainly. And a lot of them are very upset that most of the patients in the hospital now are unvaccinated. And so there's that kind of anger. So, I mean, I think that's a real issue we need to work on. I mean, I think we can work on it. The fact that the government is giving hospitals some more money for travel nurses, and other personnel and trying to support the system, is good. How much the public cares, is hard to gauge at this point. As I said, digging out some of this data, it turned out to be, pretty difficult, which surprised me because it's not in the academic literature at all. And some of them are just, press reports or reports from the Commonwealth or from the CDC and things like that. So, but that's a really good question. And I don't know the answer. I hope they still have support.
Yeah, well, I mean, one thing that I've seen in some of my own work is that on the public health side of things, there's been an effort in a lot of states to roll back public health powers, sort of as a reaction to the perception that public health officials overreached in their pandemic response efforts. I don't think that's true, but I think in states where that's the perception and that's sort of the political position that some of the leaders have taken, there have been efforts and successes in rolling back what public health officials are able to do in intervening during a pandemic. And I haven't seen that kind of extending to healthcare specifically, in terms of further restrictions, but I obviously all of those trends are connected, and I was just wondering kind of how connected they were.
Right. I'm sure they're connected. And there are lots of people who, don't like public health and they're upset about the healthcare workers and don't want to, support them as much. But it's a real serious problem.
Are there any additional questions? Hi, John. I was able to see you.
Okay, thanks. I enjoyed your talk, Dr. Hankin. I was intrigued. I saw the new issue of Scientific American that has a whole issue devoted to the pandemic and everything. And it got me thinking about the vaccine research and what that did to people who are, who are doing all this research. Did it do much to push medical research further? I saw money was there, but was it necessarily? These were radical things, genetic manipulation and things that people, they were, crazy things said about it. But what did the medical research do? It went so fast for these vaccines. What about that? Did it spur more research?
Well, it's certainly spurring a lot more research. What's interesting is that the vaccine research actually started in 2012. So they had done a lot of work on SARS, and that fundamental work made it much easier for them to start creating and producing vaccines. So that made a huge difference. I haven't seen any data on the NIH budget and how they're allocating things at this point, but that's a good question.
Okay. Well, I'm not seeing any more questions. Dr. Edwards, would you like to say something or?
Yes, I just want to thank Professor Hankin for this very important issue, and I see that Lance has put up his hand. So maybe he has an additional question, Lance.
Oh, it's an applause.
Thank you.
I was just applauding.
Just applauding, yes, well, absolutely, and to thank her very much, and to hope that she continues to enjoy the good weather in Florida, and that we will see the Goodmans back on campus in the not too distant future. And
we'll be back in May, so we're looking forward to seeing you all.
And also to remind people on the Zoom call that if you're near the FAB building on the second floor, the Humanities Center is giving out donuts in honor of what is called Fat Tuesday, or the day before Ash Wednesday, when Lent begins. So this is a moment that you can stock up on your calories and to keep you going for the next 40 days. So you wouldn't feel any guilt, and we are delighted to offer that opportunity. And it's done through it was an idea that our administrative assistant, Ariel Ferguson, brought up, and we embraced it, and we're hoping to have lots of customers outside of our suite. But that's all I have to say, and I think Jacqueline, you have a little closing spiel to give.
I do. Thank you for everyone for coming. This was a rightfully well-attended talk today. It's nice to see everyone. Thank you to you, Dr. Hankin, for giving us this wonderful presentation, especially on something that affects us all. The Humanities Center wanted to thank you by giving you a mask, how fitting, with our logo on it, and a notebook with our logo on it as well. And I'll reach out to you. I'll reach out to you shortly to see how we can get this to you.
Great.
As for everyone here, this talk has been recorded and will be available on our YouTube channel shortly. So if you wanted to rewatch it and get some more out of it, you're always able to look there for this talk and talks in the past. Have a great one, everyone.
Yes.
Thank you.
Thank you. Bye-bye.